All right, thank you, Gayatri. Hello. Hello, everyone, and thank you for joining us for the MedNews Week Keynote Conference. Our goal at MedNews Week is to bring you the most cutting-edge medical information from the leading physicians and researchers in their respective fields. My name is William Wilkerson, and I will be your host today. Just a quick note on our two founders and co-hosts, Dr. Jan Liefman, who is a physician and renowned cancer researcher, and Dr. Chandler Park, who is an internationally renowned physician, researcher, educator, and the president of Kentucky ASCO, who has published over 100 peer-reviewed papers, including in the New England Journal of Medicine, and he's the host of the nationally televised Master Lecture Series. We are fortunate to have a great team to make these events a reality. Our chairs include Dr. Chandler Park, Dr. Jan Liefman, and Pratyusha Ganta. Our organizing committee is composed of Lauren Vento, Alexander Van de Kijf, and Dr. Yavuz Saleh. Our educational committee includes Sean Jakewitz, Amaral Shimon, Pallavi Pai, Muskan Joshi, Gayatri Menon, Chorya Herschel, Madhuri Ahmad Nureri, and Asa Naik. Our associate managers are Pallavi Pai, Muskan Joshi, Gayatri Menon, Alexander Van de Kijf, and myself. Our director of video production is Sean Jakewitz, and our media director is Pallavi Pai. The moderator for today's event is Gayatri Menon. Today, we have the chance to welcome to the MedNews Week stage, Dr. Pavani Chalasani. Dr. Chalasani is a world-renowned oncologist and breast cancer researcher. In 2020, she was awarded the prestigious National Cancer Institute's Clinical Cancer Investigator Team Leadership Award. She specializes in breast cancer and is committed to taking care of patients with breast cancer and improving standards of care and outcomes through her leadership in clinical and translational research. Dr. Chalasani completed medical school at Gandhi Medical College in India. She then went on to complete her internship, residency, and fellowship in hematology oncology at the University of Arizona. Currently, Dr. Chalasani is a tenured associate professor, program director of hematology oncology fellowship, and the leader of the breast cancer clinical research team at the University of Arizona Cancer Center. She's an internationally renowned investigator that led many late-stage clinical trials to investigate novel therapies against metastatic and triple-negative breast cancer. She's a reviewer of many prestigious journals, including, but not limited to, the Journal of Global Oncology, Clinical Breast Cancer, and American Journal of Medicine. Dr. Chalasani is an accomplished keynote speaker who has spoken at dozens of events around the globe. We are incredibly fortunate to have here today to speak about metastatic triple-negative breast cancer. And without further ado, it is my honor to welcome Dr. Chalasani. Reviewer of many prestigious journals.
Can you hear me? Hello? Can you guys hear me? No.
Yes.
All right, thank you. Well, thank you for that really kind introduction. It's my pleasure to present current updates on the treatment paradigm for metastatic triple-negative breast cancer. I work at the University of Arizona Cancer Center here in sunny Tucson, where it is almost 100 degrees today. So on that note, these are my disclosures. There's no conflict with the talk that I'm giving today. Just a brief outline. I'm going to just go over some background just to get everyone up to speed and just have a baseline about some triple-negative breast cancer, then go over immunotherapy and the antibody drug conjugates, which are paving the way for new therapies in triple-negative breast cancer. As everyone is aware, triple-negative breast cancer is the biology where we have estrogen, progesterone, and the HER2 negative, the three known targets or triggers for breast cancer. They are not evaluated on the tumor specimen. So when the expression of the estrogen receptor, progesterone, and the HER2 are negative, that's when we call it triple negative. In general, the incidence of the breast cancer, when we talk about estrogen receptor positive or hormone receptor positive is the group that we commonly refer to that, it's about 65 to 80%. Whereas HER2 negative is more about 25%, about 20 to 25%, and triple negative, we call it as 10 to 20%. Now, there may be some shift in terminology with the new data which was presented in the HER2 low category. So there may be some changes coming up in our definitions and how we divide or subtype our tumors. But in general, for now, this is how we broadly define our tumor biologies. Now, Triple negative breast cancer, while we group it under one type, like the estrogen, progesterone, the HER2 are negative, they're still a very heterogeneous tumors. There have been multiple sequencing and other profiling studies which have shown that there are basal-like subtypes, there are androgen receptor rich, mesenchymal, immune activated, basal-like immune suppressed. So there are multiple subtypes, and there have been some beautiful papers which have been published demonstrating, the various the subtypes and how these are just intrinsically so different. And how do they matter? Because the responses to treatments matter, how their prognosis matters. So these are all significantly important for us to understand that even though they are all lumped together one, and that is also critical for clinical trials, because all of them are put under one umbrella, but there is just a lot more heterogeneity in these tumor types. Now, the general characteristics, it's more common in young women, African-American women, and those who have BRCA1 mutations. It is very aggressive with a high risk of recurrence. And we say pretty much most of the tumors, if they tend to recur, it happens within the first 3 to 5 years. Most patients, they are diagnosed early, say stage 2 to 3 at diagnosis. And we tend to do more neoadjuvant treatments, especially to understand the prognosis and to assess, identify those high-risk patients who are going to have a high risk of recurrence and develop distant metastatic disease, which is terminal or not curable for the majority of patients. And we have a way to assess that, and that is called PCR, or pathological complete response. That one correlates with the risk of disease-free survival very well. So we try to get that additional prognostic information to figure out how our patients are going to do long term. The 5-year survival rates for triple negative breast cancer, this is based on the SEER stage for about 2011 to 2017. But for distant metastasis, as you can see, for localized, it's about 91%, whereas for distant, it goes down as the stage increases, it goes down, but for distant metastasis, it's about 12%. So, but the clinical outcomes are improving. So there is definitely improvements we are making. And that is by increasing the pathological complete response rates, especially with the combination of immunotherapies and chemotherapy combinations. We have adjuvant capecitabine, we have olaparib in patients who have BRCA1 or 2 mutations. And we are trying to develop more effective targeted agents in metastatic triple negatives, especially with immunotherapies, PARP inhibitors, and TROP1, and ADCs. So these actually are paving the way for new treatments to come on, and there's a lot of excitement in this field. Huge, improvements are still essential, but I think we are making slow progress. With that background, I'm just going to jump into immunotherapy, the first things. So one of the key papers which was published and which is currently the standard of care is that what we call as the Keynote 355 study, and that is pembrolizumab plus chemotherapy versus placebo versus chemotherapy for patients who have untreated, locally recurrent, inoperable, or metastatic triple negative. This was a randomized study, placebo-controlled, double-blind phase 3 trial done over 210 sites over 29 countries globally. So all the patients, about 1,300 or about 1,400 patients, were randomized 2:1. I just put a snippet of the whole big randomization scheme and a very busy picture in the manuscript. But the reason I've just put this little snippet is overall, 372 patients were screened, but the final patient population was about 850 patients. They were assigned, like I said, 2:1 for favoring pembrolizumab. So about 566 were assigned to pembro with the chemotherapy versus 281 to placebo with chemotherapy. The key thing that I want to have everyone as a take-home point here is the percentage of PD-L1 positive, and especially it is for the combined positive score. So combined positive score is the number of PD-L1 staining cells, which is the tumor cells, lymphocytes, and macrophages, divided by the total number of viable tumor cells, which is multiplied by 100. So if the score is over 10 versus over 1, and they try to stratify it. So the randomization was stratified based on the type of chemotherapy, and I'll go over the chemotherapy backbone here in a second. The PD-L1 expression as baseline, and they did that by combined positive score of greater than 1 or less than 1. and previous treatments with the same class of chemotherapy in the neoadjuvant or the adjuvant setting, yes or no. The key primary endpoints were progression-free survival and overall survival. They had dual primary efficacy endpoints for this trial. And mainly they did that was PD-L1 CPS of more than 10, then CPS of 1 or more, and then the intent to treat. So they had this hierarchical staining. So if it was positive one, then they would go to the next category and group to analyze. And if that was positive, then they would go to the following category. And if one of them was negative, then the following analysis would not be done. So among all the approximately 850 patients, as we can see, 25% had a PD-L1 less than 1 and 75% had more than that. And among those, around 38% had about the PD-L1 of CPS 10 or more. Okay, so this study was primarily done in 2017, 2018, and like I said, about 1,400 patients were screened and 850 were randomized. And the first interim analysis, the data cutoff was in 2019, and they presented data. That was the first study which was presented, and it's, like I said, subsequently published in Lancet. And what, before going to the deep results, I do want to kind of just go over some of the disease characteristics of the patient population. So these were obviously patients with almost like first-line metastatic. So they could either have de novo metastatic disease or have recurrent or metastatic disease. And the disease-free interval from the diagnosis. So about a third of patients had de novo metastasis. Less than 12 months, from their completion of their systemic therapies, radiation therapy was not counted. So whenever they finished their systemic therapies, whether it was neoadjuvant or adjuvant, less than 20%, 12 months was about 20%, and it was pretty equally distributed among both groups. And then more than 12 months was about half of the patient population. The other thing about the patient population that we really need to understand is among those who had metastatic or recurrent, distant metastasis was the most common, whereas locally inoperable was about 3 to 6%. The chemotherapy, so the chemotherapy backbone, which was used in the study, was pembrolizumab with the chemotherapy versus chemo of physician choice with the placebo. And the chemotherapy choices were either nab-paclitaxel or Abraxane, paclitaxel or gemcitabine carboplatin. The number of previous treatments with the same class of drugs was about 20%, and they did not use the same class in about 79%. But as you can see, the majority of them did get more than half, and that was across all subgroups, was gemcitabine carboplatin. Paclitaxel together, but the other common one which was used was nab-paclitaxel. The previous neoadjuvant or adjuvant, as it is demonstrated here, about half got anthracycline-based regimens, 50% or more got a taxane, only about 6%, 6 to 8% got a platinum, and there was other. Because the vast discrepancy was because this was a global study, and there is definitely a variation in the standard regimens. So the main key results which they were presented initially showed for the combined positive score of greater than 10 in the pembrolizumab versus the placebo, there was a difference in the progression-free survival between 9.7 in the pembrolizumab arm versus 5.6 in the placebo arm. In the CPS greater than 1, you just combining the 75% of patients, it was 7.6 by 5.6 months, whereas the intent to treat, and that was pretty much everyone, that combined it to 7.5 to 5.6. Those are pretty similar to that. In the PD-L1, and again, this was kind of putting that together, just showing it 5.6 to 7.5, the cutoff of 10, 9.7 by 5.6, favoring the pembro here. And the cutoff of more than 20 is also something they saw, and it was 9.5 and 5.4, kind of similar to 10. Again, trying to establish, it's just very sensitive. Trying to establish what is an optimal or ideal cutoff of the CPS score for us to figure out which patient population, which tumors have this expression would benefit from this treatment. Obviously, one of the new things we always wonder when a therapy comes up is side effects, and especially with immune-mediated adverse events. And obviously, the immune-mediated ones are significantly higher in the pembro and the chemotherapy arm in about a quarter of patients compared to the placebo, because they were not getting any immunotherapy. They did have chemotherapy-related side effects in both arms. The grade 3 or higher, which actually do end up, holding dose reductions and all those things, happen in about 5% or less, and most of them were thyroid-related events, colitis and skin, but they were about less than 1%, and skin adverse reactions, the really severe grade 3 or higher, were 2%. So that is what the initial reports have been, and that kind of set the standard for us to think, okay, pembrolizumab is active, and that it has shown efficacy. Subsequently, there was a late-breaking abstract of the same study with some final results, and this was presented by Dr. Rugo at ESMO last year. And that what they basically showed was in the population with the CPS score of greater than 10, the addition of pembrolizumab basically significantly reduced the risk of death by almost 27%, and there was a 7-month difference between the arms. And benefits were less pronounced in the other 2 SS population. The median survival was about, in the greater than 1 group, was 17.6 months versus 16 months. So it was not significant. And the intent to treat group was also 17.2 versus 15.5 months. Again, not different, but in the CPS of more than 10, it was significantly different. And this was with the overall survival, which was promising because that is a gold standard that we really want to shoot for. Most of the times in the metastatic setting, we try to assess for progression-free survival, but we've actually seen more and more therapies now showing overall survival. So I think we can aim for that golden endpoint in that to show the benefit clearly in that sense. And then again, they also provided an update here at the same time for the progression-free survival because they had more long-term follow-up. And here the progression-free survival, again, 9.7 versus 5.6 months, similar to what I just presented. And the objective response rate was improved by 12% with the addition of pembrolizumab. The disease control rate, the other things that they commented on and presented was 65% with the combination. And the duration of response was also higher for these patients too. Now, following that, we had our last update, or at least so far, one of the update was this was presented at San Antonio in December, and this one, the cutoff was about June, and the median time from randomization to the data cutoff was about 3.5 months. And what they showed was the hazard ratio for the overall survival. And again, in the CPS more than 10 group, more than 10 subgroup, it was 0.73. And they presented in the greater than 1 subgroup, 0.86, and the intent to treat similar to what I was just presenting. The hazard ratios, again, for progression-free survival, again, even though the PFS was, good in all those things, definitely the key benefit that they're hitting or seeing is in the subgroup of 10 or more. And this kind of provides support. The CPS of greater than 10 is a reasonable cutoff to define the population of patients with metastatic triple-negative breast cancer who are expected to derive benefit from pembro plus chemotherapy. With that, what about the other immunotherapies, and what about, is there any other studies? In fact, one of the first things which has been approved and has been shown was atezolizumab. So in 2018, with the Impassion 130 trial, that was one of the key studies that actually paved the way for the official entrance of immunotherapy in combination with chemotherapy. And the chemotherapy backbone, which was used in that Impassion 130, is nab-paclitaxel. And this is kind of important for us to focus and realize, and I'll go over that in a minute, why. And that was as the new first-line treatment for patients with metastatic triple-negative breast cancer. That was a randomized trial, about 900 patients, untreated, frontline, first-line metastatic triple-negative. They either received treatment, with nab-paclitaxel, either with atezolizumab or placebo, kind of similar to the pembro in that end. And the co-primary endpoints for this trial were, again, progression-free survival and overall survival in the intended to treat population as well as the PD-L1. We have to remember for the atezolizumab to use the PD-L1 that they test, they use a clone with SP142, whereas with the pembrolizumab, it's a different clone that they use for testing. So about 1,200, it's a busy slide, but I'll just go over quickly. About 900 were randomized 1:1. So that is one of the key differences. And what they showed was the initial results actually demonstrated a benefit in the progression-free survival in the intent to treat population. And that was about 7.2 versus 5.5 months. And in the PD-L1 positive, which is 7.5 versus 5. That was one of the first publications and the presentations actually, which came out, which showed that there was a benefit and it reached a statistical significant levels, but it was about 2 months, 2.5 months. The overall survival did not reach the significance initially, but but then they started actually showing there was a trend and it finally did hit. It was 25 months in the atezolizumab plus the nab-paclitaxel versus 18 months in the placebo nab-paclitaxel, especially in the PD-L1 subgroup. However, it was powered for the intent to treat population and not the PD-L1. So it was it was not formally not allowed to be tested because of the statistical plan, but that is what it showed was in the PD-L1 positive subgroup, there is a clear overall survival with almost a 7-month. And that, like I said, that is important. And based on that data, actually, the combination of atezolizumab and nab-paclitaxel was approved by FDA as for use in first-line therapy for metastatic triple-negative breast cancer with the PD-L1 positive expression. Now, because nab-paclitaxel for the access is there, they did recommend getting a confirmatory study, and that was what led to Impassion 131, and that was the subsequent study which was again presented in 2020. And this one, again, similarly, phase 3 double-blind placebo-controlled study. This enrolled about 650 patients. Again, metastatic or unresectable, locally advanced triple-negative breast cancer, and no prior chemotherapies or targeted therapies for advanced disease. So patients were randomized to either weekly paclitaxel here. And so paclitaxel is different from the nab-paclitaxel, as I'm sure most of you guys are aware, because of the pre-medications that we use. But here, the main chemotherapy backbone was paclitaxel. And again, it was either atezo versus placebo in a 28-day schedule. The main thing was differing was the primary endpoint was progression-free survival, but it was investigator assessed, and it followed the hierarchical testing, like similarly to the one that I mentioned earlier in the Keynote 355 study, that if they meet the first the endpoint, that was triggers to get the second endpoint to be done. First, they were going to do in the PD-L1 positive population. If that was positive, that would actually trigger the intent to treat population. The secondary endpoints were overall survival, but that would be only formally tested, like I said, in the hierarchical testing design, only if the primary endpoint was positive. This study actually was negative. I mean, there was no difference, and it was a surprise, and it's also very humbling to know that we need to study more. I mean, not everything is a clear-cut answer, and we just need to investigate that. So I'm going to kind of present both these trials side by side just to know what the key differences were and what can potentially explain some of the things which came up from this study. And so, the patient population was slightly different. Obviously, Impassion 130 had, higher sample size compared to Impassion 131, but for first-line metastatic triple-negative in both categories. Both of them were randomized, but this one 1:1 and this one was 2:1. It was both of them were placebo controlled. It was atezo or placebo combined with nab-paclitaxel, whereas here it was paclitaxel. The primary endpoint, again, we talked about the hierarchical design in both. The PFS in the PD-L1 positive intervention versus control was 7.5 months, like I said, and versus 5 months, and here it was 6 versus 5.7. Whereas in the intent to treat, again, overall it was the same, but here it was pretty similar, 5.7 to 5. Overall survival, again, this was 25 versus the 18 months, which, that 7-month difference, which got all of us excited. Here it was 22, and actually the control arm did better in this, 28 months. The other one was in the intent to treat, again, it was 21 to 18 months, and that was the whole population in the Impassion 130. Whereas again, it was 19 and the control arm actually numerically did better. And that was concerning. Now, if you think about what were the other key differences, I mean, the median age was kind of similar all across. The PD-L1 positivity status of the number of patients who were enrolled with those tumors, pretty, similar. I wouldn't say that's much different. Those with liver metastasis, thinking about if you're enrolling patients with more sicker patients on one, and that is why the results were there. So they looked at liver metastasis that was similar, in both studies, and we can think more than 3 metastatic sites was pretty even. Now, prior taxane treatments, prior anthracycline treatments, again, to know if there is a more intrinsic resistance or these are high-risk tumor. How many were de novo triple negative? Numerically, it's a little bit more so in impassion, but again, not that much different. The use of concomitant steroids, as everyone is aware, because immunotherapy, we are trying to stimulate the autoimmune or immune system. So giving steroids is kind of counterintuitive and it actually acts against. So that is the only thing. But for the most part, for the paclitaxel, they got about 8 to 10 milligrams of dexamethasone. And that was at least for the first 2 infusions. They do not have data. Subsequently, how many patients did continue to get the steroids, because that is a medication, and paclitaxel does have pretty significant infusion reactions now. So, but that is what the differences was. The other things we really don't know is there have been some studies which did show that nab-paclitaxel was slightly better than paclitaxel, even though it was not significantly different, and we still use both of them, but the response rates were higher. Is that kind of what drove in the impassion 130 versus 131? We do not know. The other status information that we do not have is the number of patients who have BRCS status, because those who do have a better responses and prognosis. So were they more in 30 versus 131? And we do not have the data. The other thing is drugs get into our body. What is the BMI? How are they metabolized? So, other lot of questions, that we really don't have the details with. But given that the impassion 131 was actually negative, and in fact, some of the arms, like I showed the data, the control arms, had numerically better, the atezolizumab was actually, the indication was removed. Currently, for triple negative, the PD-L1 expression threshold for the positivity, they combine the CPS score of greater than 10 by immunohistochemistry, pembrolizumab with the chemotherapy, and the backbone is either nab-paclitaxel, which is the albumin-bound paclitaxel, or paclitaxel, or gemcarbo, right? That is the backbone. That is a category 1 indication in the NCCN, and that is a preferred first-line therapy for the tumors which have the positivity. So with that, I'm going to just go switch to the antibody drug conjugates, which have been really exciting to kind of show. And one of the first ones which has been published and approved is sacituzumab govitecan, or SG, to keep it simple. That actually targets a TROP2, and TROP2 is a transmembrane calcium signal transducer. It's linked to tumor progression or poor prognosis. So it is highly expressed in approximately 80% of breast cancer, regardless of subtypes. So in the triple negatives also, it was, because the expression was really high, they did initial phase 1 studies and actually really saw pretty remarkable responses, which kind of accelerated more testing in that subgroup. And it showed benefit, and I'll show in the ASCENT trial, the confirmation trial, and it is approved for patients currently in our clinical practice for metastatic triple negative with either 2 or more treatments or more than 1 in the metastatic setting. The key study, and this is the one, and this, I think they did a great job in just putting the key highlights. NEGM did a really awesome job here. And this one was the ASCENT trial, which got sacituzumab approved to, this was the big global study, is the phase 3 open label randomized study. And basically it was 530 patients randomized 1:1 for sacituzumab or chemotherapy of physician choice. And basically what it showed was the progression-free survival was 5.6 months compared to 1.7. And these were pretty heavily treated patients too. The grade 3 or 4 toxicities were, numerically a little bit, higher, but they were still tolerable. And this actually improved the progression-free and subsequently overall survival. So this got approved. Now, kind of similar to that, now we have another new kid on the block, and that is datopotamab deruxtecan. And this was actually presented, the last abstract that I'm going to comment was presented by Dr. Ian Kropp at San Antonio in 2021, just last year. And that is antibody drug conjugate directed against the trophoblast, again, TROP2, and that has been showing promise. And this was presented. I'm just going to go with DATO-DXd to make it simple for all of us. These new names are getting to be tongue twisters for most of us. It's an antibody drug conjugate consisting of the humanized anti-TROP2 IgG monoclonal antibody. And it's conjugated to a potent topoisomerase 1 inhibitor payload via a stable linker. And these are, all these antibody drug conjugates. And we have another one which is currently in clinical practice, and that is the trastuzumab deruxtecan. And deruxtecan is a pretty potent payload. So basically, you have the target and the antibody, you have a linker, and then you have the chemotherapy. So these get delivered. These are given IV for right now. Most of them, they're given IV. They attach to the target, antibody or the receptor. They are taken, they're internalized, and then through the lysosomes, and they have enzymes released, the linker or the cleavage is broken and the chemotherapy is delivered. Sometimes based on the potency of the chemotherapy, all they need is their target receptor to be expressed a little bit if there is a really high potency. And then the chemotherapy is also pretty potent. It can actually have diffusion into the surrounding cells. So not every single cell needs to have this high expression. So they're really trying to get potent antibodies with a good, with linkers, and to have this really potent chemotherapy payloads, which are acted on so that they can deliver it more targeted. And they can also have bystander effect to the other cells surrounding, which do not have or need to have such high expression. So trying to take advantage of both of those things. So deruxtecan, like I said, trastuzumab deruxtecan is actually approved, and the Destiny-04, which just got presented. Since it was not completely in triple negative, I didn't add on here, but it showed pretty cool results just less than 2 months ago now, or approximately 2 months. So very exciting results there. But this one also, again, showed very promising results. The preliminary results from the phase 1, so the TROPION was a pan-tumor study. It was looking at DATO-DXd against the TROP2. So it was pan-tumor, the non-small cell lung cancer that was presented in ASCO last year, 2021, and the triple negative was also presented, focusing a little bit on ESMO of last year too. And these are the updated results from the triple negative cohort. And what it showed, like I said, it's a phase 1 multi-center. So the dose escalation results, it was given about 6 milligrams per kilogram IV every 3 weeks. But there were 2 patients, I think, before they got on who got a little bit higher dose. But they also had safety and efficacy, objective response rate by RECIST, by blinded independent central review. And what Dr. Kropp actually presented was 43 patients with triple negative breast cancer. They received more than 1 dose of the DATO-DXd. So at least we are able to assess, especially for safety, which is critical for all these new exciting ADCs coming on. But we also have to ensure how is it affecting the normal and what is the side effect profile we are looking at. And with 27 patients, we're actually continuing at the time they did the data cutoff, and 16 patients discontinued treatment because of disease. The median age was about mid-50s. 95%, so majority of the patients had got at least more than two or more than 2 lines of therapy. And what was interesting was at least 7 out of these, or 16%, had prior sacituzumab. Sacituzumab is another TROP2. So again, thinking about the govitecan, maybe the payload, maybe that is different. And again, this is something we need to look and develop into to understand about the patient populations and the prior treatments, as all these interesting new treatments are coming up, but then how do we sequence it, or things like that? Do we have data? We are not, but we also have to look into trials like this, where here patients got sacituzumab, govitecan, and then the DATO-DXd did show benefit. So I think things we need to understand more, but it's very interesting. So maybe showing, because they have different payloads, that there is still role for TROP2 antibodies, but we, more studies, and we need more things too. The median duration of treatment was 2.8 months. Among the 38 patients who were evaluable for response. The response rate was about 49%, with 15 of them were confirmed. Three, they were still waiting for by central review, 15 based on the indicator assessment. The disease control rate was about 5%, and the median time was about 1.3 months, so about 2 cycles. There were a lot of treatment, like I said. The main thing was treatment emergent adverse events, and those are very critical for us to keep an eye out for and to understand. Pretty much all they saw some kind of adverse event, but the most important ones, if they were more than 30% or grade 3 or more, nausea, stomatitis, alopecia, and this is important. It's important for us to know because those are critical side effects, for a lot of women and who are undergoing treatments and things too. So these are all important clinical meaningful side effects too. Nausea, stomatitis, alopecia, vomiting, and fatigue. So the preliminary results show that Dato-DXd demonstrates promising anti-tumor activity with manageable safety profile in patients with the previously treated or advanced metastatic triple negative. Confirmatory studies are warranted more, obviously. So hopefully we are looking forward to more studies. And briefly, like I said, at ASCO this year, we had data presented on Destiny-04 study about the trastuzumab deruxtecan and the HER2 low. So as I mentioned earlier, triple negatives where the estrogen, progesterone, and the HER2 are all negative, and the HER2 negative is basically by immunohistochemistry. So it is, by immunohistochemistry, the classification is 0, 1 plus, 2 plus, or 3 plus. 3 plus is positive. 0, 1, and 2, 0 is negative, including 1 and 2. But if they are, most of the places do what we call as a confirmation, like FISH. So generally not for 1 plus, 2 plus, it's supposed to be equivocal, and then the FISH is recommended by the guidelines. But clinical practice varies with a lot of individual organizations and pathology labs kind of doing FISH as a confirmation for 1 and 2 plus, more so than 0. And if the FISH is negative, then the tumors would be classified as HER2 negative. But what they have demonstrated was if their immunohistochemistry, the HER2 was either 1 or 2 plus, and if you use trastuzumab deruxtecan, there was still a benefit in progression-free survival and overall survival. So in the major study, majority of the patients were hormone receptor positive, the HER2 low, but there were about 60 plus patients with the triple negative, like the classic triple negative, or at least not classic, I should say. How they are classified as triple negative currently, they were also included, and it did show benefit too. So there's definitely which is going to come too. So with a lot of treatments currently available, how do we go or how do we manage? And I think for me as a clinician, when all these treatments are coming, the most important things that I want to consider before I go into is what are the prior treatments? So is it de novo metastatic versus was it a tumor which was seen, and how long was the treatment in the neoadjuvant or the adjuvant setting? Because they actually do demonstrate sensitivity or resistance to therapies, and what were the treatments that we gave? What is the status of BRCA? What is the status of the PD-L1 of the tumor? And those are critical, important from the tumor perspective in the treatment. However, the other essential thing we need to consider is what are the toxicities that the patients have experienced with the prior chemotherapy? Was the neuropathy so bad that we cannot use one of those as a backbone? What is the performance status? What is the patient's preference and other social aspects? How far do they live? Are they able to make the treatments, and other considerations that we need to go and kind of do that, take into considerations. But the good thing is we are making the right steps in the right directions, I'm hoping, but we need to understand more and go from there. With that, I'm going to open it for questions. And I really want to thank the organizers for inviting me to give this talk.
Yeah, thank you, Dr. Chalasani. Thank you so much for that wonderful presentation. As she just said, we will now move into our question and answer segment. Quick reminder to our audience, if you have any questions, send it to one of our moderators via the back channel on Clubhouse. Before I turn over the mic, I'd like to ask my own question. Dr. Chalasani, what do you foresee as one of the greatest challenges in improving triple negative breast cancer outcomes?
I think the biggest challenge that we are slowly trying to do is, targeted therapies, right? Like if you have targets, you're able to develop it. So we are learning about the TROP2, we are learning about other targets that we are trying to exploit and, take better and develop an opportunity to develop novel therapies. So I think that is one of the key things. There are not pathways that we are understanding, which are more active. But again, lumping all triple negative under one category is also very challenging. As I showed in the first few slides, the biology is so different and they have different responses to treatment. So I think those are critical for us to understand as we are developing new therapies or things too. But one of the key challenge has been it is rapidly growing. We don't have targets, so it's been a challenge in developing treatments too.
Thank you.
Thank you so much, Dr. Chalasani, for that amazing lecture. My name is Gayatri from London, and I'm the moderator over here on Clubhouse. So we have some amazing questions ready for you for our Q&A portion. So I'll be asking the first question. So Doctor, my question is, statins have been recently shown to have some anti-tumor effects. And as an additional therapy, they also play a role in P53 degradation in triple negative breast cancer. So do you think they have equal efficiency in cell lines with maybe conformational or contact type mutations? Do you think the type of mutation plays a role in the efficiency of statins?
That's a really good question, and they have been explored, and there have been some studies. I mean, statins, and along with also proton inhibitors, things like that. So one of the new things in breast cancer is we are able to test a lot of some interesting pathways along with doing a preclinical data and also to look for biomarkers and other things we are able to treat patients in the neoadjuvant setting, right? So we have like PCR as kind of a surrogate endpoint to actually then go and directly look in the metastatic too. So there have been studies that have shown them to be promising, but subsequently they have not. And again, I think it all comes down to patient population and selection, or I should say in a way that subtyping, lumping everything is. And so they're not used in standard of care or things because they have not been shown. But again, I think it just comes down to the subtypes that we are trying to test or, just figure out which ones work more or things. But there's definitely data, and there have been some studies that showed promising. Thanks.
Thank you so much, Doctor. That was really informative. So for the next question, I'll be passing the mic over to Pratyusha. Thank you, Gayatri. Thank you, Dr. Chalasani, for your amazing lecture. My name is Pratyusha. I'm a third-year PhD student. So I have a question regarding the population that you test in your clinical trial. So in any of, you studied different metastases, including liver. Did you see any signs of bone metastases in your population, especially the ones which were PD-L1 positive? And as a follow-up question, did the respective treatment remedy the osteolytic bone destruction? Thank you.
So that's an interesting question. So one other thing is for this, for the patient populations in all the studies, they need to have measurable disease by RECIST 1.1. So by default, that means bone-only lesions. For patients with bone-only lesions, they would not be eligible. Now, having said that, most of the patients do have bone disease, but triple negative also does tend to go a little bit more to the viscera. Hormone receptor positive, HER2 negative tends to have bone only, more, whereas triple negative and HER2s tend to have more visceral. We do not have data specifically looking at osteolytic or things activation. There is some data more so in the hormone receptor positive, but not in the triple negative. But I think that's just because of the difference in the metastatic sites of recurrence in those things.
Thank you so much. Thank you so much, Doctor. And for the next question, I'll be passing the mic over to Madhuri.
Thank you so much, Dr. Chalasani, for this amazing lecture. And I was really interested in learning about the new immunotherapies and all the drugs. So my question is actually, with tumor heterogeneity being one of the primary causes of resistance to therapies, how do we understand the role of chemokines in modulating this heterogeneity while treating triple negative breast cancer, since it's a more aggressive subtype?
Very important clinically relevant question. I think the short answer is we are working on it. I'm sure everyone is. Right now, they are not clinically actionable. So we do not do them in routine testing, or I use that. I know it's different, but I don't know how to treat it differently. And based on these, again, these studies, they enroll all patients. We haven't actually subtyped it. They are working on more specific mutation targeted studies. And like I said, all these studies, a lot of things we can learn from the biobanking to figure out was there's one subtype of things. But again, when we do it in the extra, going back and doing exploratory analysis, but again, the studies have to be powered to understand this is what the difference is. So I think as we are learning more and we will be able to understand what is the baseline expression, how much are they changing the treatments, where we'll be able to also design and power trials, to actually study and answer each one separately. But for now, all of them are still there. We are understanding and they're trying. There's a lot of, the biobanking, like I said, for the trials is the critical thing. I mean, that's something I always advocate for, and that is very critical. So, but I think we will learn more, but nothing right now in that sense for clinical applicability.
Thank you so much, Doctor.
Thank you so much, Doctor. That was an amazing answer for that question. So for the next question, I'll be passing the mic over to Asta.
Hello, Dr. Chalasani. It was really great session from you. And I have a question that there was an article which was very, very famous on internet, that effect of sleep cycle on breast cancer metastasis. Would you like to comment on that?
I'm sorry, can you repeat that question again?
Yeah, so the effect of metastasis, effect of sleep cycle on metastasis.
Phoebe, I can repeat. She asked about the effect of, there was an article she read about the effect of sleep cycle on cancer metastasis. If you have any insight on that.
Chemo cycle, I'm sorry.
Sleep cycle.
Sleep cycle. Oh, very interesting. Actually, there are some more studies that we are learning about circadian rhythms and the release of various pro-inflammatory, anti-inflammatory, cytokines, chemokines that they are doing studies. And actually, someone reached out to me recently. He does a lot of research in sleep cycles or things, just to see if that would improve. I think there is biological, some biomarker-based data about, linking with, like I said, about all the inflammatory cytokines and chemokines. Now, this is all hypothesis generating and very, very important for us to understand. I don't have anything, but, when patients ask me, about their diet or exercise or what do they do, I always say one thing is from diet. I strongly believe moderation is the key, because going on one or the other is hard. There are studies looking at ketogenic diet, if it would make chemotherapy more sensitive, and there are some studies going on too. So maybe when we learn, maybe during active therapy, they need to be on certain type of diet to make it more effective, as long as they're able to tolerate it. Because, long-term diet is a lifestyle change, and that is a whole different way of commitment and things like that. Strongly, if anyone is motivated and wants to do something, it is awesome. But I also think, it's essential to get the right kind of nutrients. So eating healthy is the key, what I always say. And especially for patients who have early stage also, I shouldn't say especially, it is important for all the patients. But patients with early stage triple negative breast cancer, all things, they are so worried about cancer recurrence. And, that applies for all breast cancer patients and all. I have to frequently remind my patients, the number one disease which is going to kill women is heart disease. It's not breast cancer. But we need to remember, what are the therapies we're getting? What are the other, with all these treatments that they are undergoing, is it putting them at increased risk for heart disease and other things? So it is essential to be active, to eat healthy, and have a good sleep cycle. And I think that just goes into taking care of yourself, take care of the body, take care of the mind, and then, go with what science has so far. We still haven't made the complete, we don't have the home runs yet, but hopefully we will get there, right? But we need to also help other ways, which are slow steps, and everything will help. So I don't have an answer in where it is, but there is definitely data about circadian rhythms and how they change the profiling of, metabolomic profiling in the body, which likely has influence. But there are studies going on, and hopefully we'll learn more.
Thank you so much, Doctor, for the wonderful answer. And I'm really looking forward to the studies that are going on, sleep cycle and breast cancer metastasis. And I hopefully will be following up that in the future. Thank you so much.
Yep, absolutely.
Thank you so much. Thank you so much, Dr. Chalasani. That was an amazing answer. So for the next question, I'll be passing the mic over to Harshal.
Yeah, am I audible?
Yes.
Yeah, Harshal, go ahead.
Yeah. Thank you, Dr. Chalasani. It was a great lecture. So I would just want to ask that do diet have any role or importance in breast cancer therapy outcome? And also, according to you, what will be the best advice for the patient of breast cancer in context of diet?
Yeah, so like I said, I think moderation is the key. So I don't tell them to go on any kind of extreme diets or anything. I think it's important to make sure they get all their nutrients. I do think in general, overall eating healthy, eating less processed foods is just better because we really have to minimize with interactions. One of the key things I will mention, while as we are, like I said, healthy diet is the key. And I always talk to them about eating more complex carbs, maintaining the proportions and things. But at the same time, on that context, the key thing is a lot of patients ask about supplements. And I think it is okay. We do have to also take them with a grain of salt. A lot of them actually end up being significant financial burden for the patients you underestimate. That is $1 billion industry. I mean, there is a reason because, they are commented as, natural things. I mean, I'm not trying to say they are not active. It is just that for me, to understand, I want to make sure they also have or shown, just because the preclinical data and what the supplement has like anti-immune effect doesn't mean, is it similar to pembrolizumab? Probably not, because I think it would have been packaged into a drug and probably already tested if it did. So we just have to take those things with a grain of salt. However, a lot of patients, a significant proportion of patients have very strong beliefs, and I think we really need to respect that. My approach has always been, I'm not trained in supplemental medicine. That is not my expertise, but that doesn't mean it doesn't work. It's just that I do not know. And patients are more open, when we come with that approach too. So I talk to them. I try to make sure there's no interactions with the chemo or the immunotherapies or any other new antibody drug conjugates we are. Actually, NC has a beautiful website where you could do an interaction check with supplements and with the treatments too. So through NCI, it's really cool. And you can check for those things and talk to the patients. And if it makes them feel better, and maybe it is effective too, as long as there's no harm, I think it is reasonable. But I do talk to them because a lot of them, like I said, significant financial burden, and you don't want to come up saying, oh, that's not going to be active. We just don't know that. So I think supplements and the same thing, for diet too. If someone wants to try something, I think it's reasonable. The question is making sure they know if when they're changing their diet or spending like few $100s trying to empty their fridge and buy new ingredients, the question is it actually going to change their response or change their survival or things like that? So I think we have to emphasize and explain that it is good overall. I think you might feel better. And if you feel better, you will take treatments better too. But it has not been demonstrated to have a benefit too. But I think, interestingly, for patients to know if the treatment is going to work or not, they need to get treatments. And if whatever they do, if they make it feel better to get it, as long as it's not harmful, it's reasonable. But short answer, moderation is the key. Going on any kind of extreme diets, they are okay for short run, haven't really panned out on long term. Not personally, also have never been able to.
Thank you so much for your insightful answer. It was very helpful.
Thank you so much, Doctor. And Dr. Yan will be asking the next question.
Thank you so much, Dr. Chalasani. We truly appreciate the insightful knowledge that you have bestowed on all of us today. My question is regarding the future of immunotherapeutics and breast cancer. Not too long ago, Prisma Therapeutics, which is a small-ish to mid-tier company in Pennsylvania, got FDA approval for their phase 1, which did show preliminary promising data. and they have one of the first two macrophage-based CARs targeting HER2 in breast cancer. Now, this is different than the typical CAR T cells that we are used to, but the therapy has shown promising efficacy. Given the promise of other family members of the CAR family, what is your perspective on the broad spectrum implementation of single agent or dual agent targeted cellular therapies to effectively treat and possibly cure breast cancer, especially complex ones like triple negative breast cancer down the line? Thank you so much.
Yeah, well, they are definitely doing clinical studies. I think the key thing is identifying the patient populations and ensuring about the target. So in addition to CAR T, they're also exploiting or in actually studying if they could use another drug like, STING pathway, or, LAG, trying to target those to work on the immunomodulation of the tumor microenvironment and then delivering checkpoints. So kind of making them way more sensitive to checkpoint inhibitors and doing this. In addition, in that same line or the same line of family is they are definitely doing studies with the CAR T too, and also some with like bispecific antibodies or things where they're directly targeting and actually ensuring they can have more tumor lysis. I think, like I said, oncology is very rewarding in terms of just taking care of the patients, but it's also a very exciting field just because of the immense research and the rapidly changing field evolving, pretty much every single day. It's very exciting. So I think, hopefully we'll see some really remarkable therapies, coming up for this. For this one, I mean, triple negative definitely is very, especially metastatic, is a devastating diagnosis. So it is a clear unmet need, and there's definitely a lot of interest and focus for a lot of novel immunotherapies or immunotherapy combinations with immunomodulators, are also looking at CAR T-based therapies for this one. So studies are ongoing, so we have to wait for the results.
Thank you so much.
Thank you so much, Dr. Chalasani, for your very insightful answer. For the next question, Muskan will be asking the next question.
Hello, Dr. Chalasani. First of all, I'd like to thank you for such an amazing lecture and a presentation. I certainly learned a lot in such a short span of time. So thank you so much for your amazing presentation. My question to you is, what do you think is the future of implementation of immunotherapy in the treatment of triple negative breast cancer? I would love to hear your thoughts on this. Thank you.
So in the metastatic setting, pembrolizumab is approved for PD-L1 positive in the first line, and that's has been approved and is kind of standard of care. In the early stage, so stage 2 to 3, there is another large randomized study with pembrolizumab, and that is the Keynote 522 study, which I didn't present because I was focusing on metastatic. It has shown improvement in pathological complete response and event-free survival for those patients and overall. So pembrolizumab did get approved in the early stage setting too for stage 2 and 3 triple negative breast cancer. So if we are able to prevent more number of patients from developing metastatic triple negative breast cancer, that's even better. But now with metastatic, pembrolizumab is approved, but there's definitely research going on in early stage also to ensure if you're able to just improve outcomes, because majority of the patients do present with early stage, if you're able to improve outcomes to actually prevent metastatic breast cancer from developing in those patients too. So it is approved currently.
Thank you so much, Doctor. And for the next question, I'll be passing the mic over to Ahmed.
Hello, Doctor. Thank you so much for this amazing keynote. My question is the following. So you're also an educator. Can you discuss the synchrony between high quality patient care and educating the next generation of physicians and physician scientists?
I think that's a very good question. I think all of us can do excellent patient care, but I think the key things, like I always talk to my fellows, is understanding it. Like I put in a couple of slides. For me, whenever I'm presenting or giving them their talks, I always try to emphasize what the patient population in the trials were and try to really help and, dig down and most of us really do is like understand the trials, understand the patients it was tested. Is that replicating real world, what it is? Because a lot of times they could be approved, but was that even tested in that setting, right? So, they do, but the question is how much do they replicate the real world? Most of the companies do have really smart people on the DSMB boards and the steering committees to ensure they are, but that is the one thing that I do talk to them. And that is from the clinical practice end too. Like I mentioned earlier, oncology is so rapidly evolving to make sure they understand their trial designs or things and not having to depend on someone else's interpretation to kind of help us, understand that, especially coming from the pharma. I'm not trying to say that they provide any biased information, but at the same time, you would want to understand and kind of interpret the results to helpful. So hopefully those are skills we try to really instill in our fellows to ensure that they're able to generate the data and things like that. Now, physician scientist is a very broad word. It could reveal to based on participating in trials or doing the things. Not everyone wants to do that. I think patient care is very, very rewarding, and there is a significant number of us in oncology who would just like to be and just taking care of patients and getting them through their day-to-day stuff and helping them ensure their quality of life is good too when they do have advanced things. So I think it is, end of the day, it is up to what speaks to the heart and what makes that individual physician, happy and what to do that. But on the same note, when our fellows, whether they go into private practice or pharma or NIH or, stay in academia, we try to install the basics of how to know or how to understand results, how to interpret results, how to even do the sequencing when they're talking about all these biomarkers, what do they mean or how are they integrated, so they are able to interpret the results and make sure they apply them to practice too.
Thank you so much, Doctor.
Thank you so much, Doctor. Ensuring quality patient care is vital. Thank you so much. For the next question, I'll be passing the mic over to Pratyusha.
Hello, Doctor. Sorry, I just have one other question. Something similar to what Dr. Yan asked. I would like to get your opinion on the use of CRISPR technology or even gene therapy in the future against breast cancer treatment. Do you think that they will be more the patients will be more advantageous? Do you think it will actually be more promising and have more therapeutic efficacy when compared to the current treatment? Thank you.
So, I'm not very, very experienced in all those technologies, but from my limited knowledge and understanding, CRISPR and other gene therapies is when we are able to identify one gene source or, a couple of gene sources, but identify that as a linkage. So in a way, like for hemophilia A or B, it's a little bit more, the gene therapy is a little bit more directly applicable because we know the gene which is deficient and we are able to affect it. So that kind of comes with CRISPR too. Cancer, unfortunately, is very complex. So it is just not one thing. There have been mutations where the big one is the P53, which kind of gets knocked out. And then, subsequently, there's a lot. So it's a big mutation or there's a deletion of P53. So when there are deletions versus insertions or things, there's more direct application. But like I said, but because it is just so complex and changing, it all just comes down to what time is it? Is it just going to be constant, right? So that at least that is how I understood or I know about CRISPR or gene therapy. So I think they are doing research, but in general, not that I'm aware of. And again, it doesn't mean it is not happening. It is just not something I'm very familiar with. In general, but more about understanding, but taking it from a broader concept and not direct one gene because we don't have it. Now, if there are preventions for those who have BRCA1 or things for deletions or some mutations, I do not know. But again, the other one, most of them just have one gene, right? But the other gene is still functional. But over time with epigenetic or other environmental exposure, the other gene gets hit too. So there's a lot of things which happen. So it's just hard, I think, in that way to target, but doesn't mean it cannot be. So not in my knowledge or things understanding, but I think from what I understand our things. I think some of the challenges was there, but that is what science is. It's so fun, and what we do is so amazing because we are able to take and apply from one things to another, and just do cross pollination from other different things, and see what's better too.
Thank you so much, Dr. Chalasani. I agree with you. Oncology is a really exciting field. We find new things every day, and we always undiscover a new pathway and new type of interesting knowledge every day. Thank you so much.
Thank you so much, Dr. Chalasani. I really learned a lot listening from you. So for the last question, I'll be passing the mic over to Rabab.
Hello, doctor. Myself, I'm Rabab, a third-year medical student. I would like to thank you for your great presentation today, and it was really interesting and a very knowledgeable session. So my question to you is, for our younger attendees just getting into medicine, what inspired you to pursue medicine and eventually oncology? And as a follow-up question, has it lived up to your expectations?
So the simple answer of why I chose medicine was because my mom told me to, otherwise I wouldn't be able to come into the house in a way. So a simple answer, like I really wasn't sure. But I always gave my mom a hard time that she forced me to do medicine because I was like happy-go-lucky. But honestly, that was the best thing ever, because I do think, especially oncology, it is my calling. Like, this is what I was meant to do. Like, there's nothing else. Like, I've always found, you hear sentences like, what excites you to go to work, or, something is your calling, and, all these like cheesy sentences that you're like, oh, what do they mean actually? But it does. Like, Monday is my favorite day of the week because I'm looking forward to go to clinic, or looking forward to go to my lab, or talk to my fellows. Like, I literally wake up getting excited. So vacations, like, I'm waiting to come back because I want to do this, and not needing to, like, it's not things. And I'm not sure if it'll happen for everyone or not, but I'm glad it did. And there's nothing more I would do other than doing breast cancer, teaching and doing the research. So that I think that's the complete package. I do not know if only doing one would have made me so happy, but I think I'm able to get all three to kind of really, stimulate me every single day and do what I do, everything. So no matter what the reason is, you're doing medicine, including being forced to by my parents. I think it is really, you can find what you really love. But if not, do it for what the reasons are, so that you can have meaningful benefit from that every single day. Otherwise, it's hard. It's different from other jobs. I don't want to say that, it's very, directly impactful. I don't want to like undermine other careers. I think everyone does, but what we do directly affects another person on a day-to-day basis. So I think that is very critical. I mean, when it's a direct one, global impacts and things, like I said, all careers are important, but what we do is also pretty essential. So when you love it, they see it too, and they know you care about it because you care about what you do on a single basis. So the main thing that I would ever say, if someone is aspiring to go into medicine or subsequently do it, is you will be able to find it. I mean, there are quite a few of us who did. And when I heard about all those sentences and rainbows, I rolled my eyes and I was like, okay, whatever. But it does happen. So you just need to find it. And, just go for that, because that'll just change your daily life. It will. That's all I can say. It does.
Well,
Thank you so much, Doctor.
thank you very much.
Thank you so much.
Our question and answer segment, but I'm going to turn over the mic to Gayatri and for closing statements.
Thank you so much, Doctor. I think it's true what they say, that when you do what you love, you never work a day in your life. So that was an amazing way to end our Q&A. I wish we can go on. However, we are reaching the end. Thank you so much, Dr. Chalasani, for the wonderful talk. Thank you so much, Billy, for hosting. And on behalf of everyone here on Clubhouse, we are so incredibly grateful to have you here on MedNews Week. I cannot wait to rewatch this session along with the others. Thank you to all of our panel members, attendees from all different platforms for your participation and questions. If you missed this lecture, fret not, you can replay it here on Clubhouse or on YouTube as well. So Billy, any last thoughts?
No, thank you so much, Dr. Chalasani. Today was a fantastic experience, I think, for everybody. That's all.
Thank you for inviting me again.
My pleasure.
So for those on Clubhouse here,